Sorry, I have to take myself off from the picture.
It's okay. Both are visible clearly.
No, I wanted to turn off my video, but I failed to do that.
No, just don't make it off. It's good. Please continue.
Right. Okay. In that case, let's go to what we shall be discussing this morning. This morning, I'll be talking about a very pertinent clinical condition, and probably underpaid attention is not paid attention to. This is a clinical condition where we probably may not suspect to have as a major problem. But I think at the end of my presentation, I will be convincing you that it is an important clinical condition for us too. So in my presentation, I will be talking about something that you all know very well, source and physiology of vitamin D, including its metabolism. And I'll be talking about hypovitaminosis D and its clinical implications. And I shall touch upon the very important topic that I wanted to share with you, how important this clinical condition is under the tropical sunshine, where we boast of 13 months of sunshine in this country. Do we really need to worry about it? We'll see some evidences that we probably need to worry about it as much as others do. And finally, I'll touch upon a little bit of the therapeutic or supplemental part of vitamin D clinical management. The vitamin D history started quite some time back. People started observing rickets in the 60s, in the mid-60s. And then in the industrialized countries like Great Britain, rickets have been recognized in its clinical manifestation, although was not initially known to be rickets, but industrialized cities started to show children that have got deformed legs. And this, people did not know what this is all about, but at least there were reports of deformed lower limb skeletal structures. And it was not until the late 19th century that sunbathing was important in preventing these deformities of rickets. Then vitamin D as a structure has been identified in the middle, about close to the middle of the 20th century in 1936. So this is the first time that vitamin D has an identity of a clinical structure that was identified in this period. This is what vitamin D looks like in its biochemical form. People call vitamin D a sunshine vitamin for obvious reasons. And calciferol is a generic name that is given to all forms of vitamin D. And vitamin D is formed on the backbone of cholesterol structures. So there are 4 cholesterol rings. As you can see on this picture, there are 4 backbone cholesterol structures. So vitamin D is a hydroxylation on this backbone cholesterol structure. Why is vitamin D significant? These days we have pools of informations about vitamin D. The studies are very abundantly coming up into the scientific community. And now we have thousands and thousands of publications on vitamin D. And now we have started to recognize that vitamin D probably has got important clinical implications beyond the very hard fact that we know as a skeletal abnormality, musculoskeletal abnormalities related to vitamin D. Now we go beyond that. Extraskeletal effects of vitamin D is now clearly coming up in scientific research and clinical observations. Is vitamin D a vitamin or beyond? People believe that vitamin D is not simply a vitamin. Vitamin D is a hormone. Vitamin D is a hormone because calcitriol, which is a very active structure that we have at the end of the process that has an effect of a vitamin D, is very much similar with many of the steroid hormones. It has got a clinical, structural similarity between estrogen, cortisol, and testosterone. These are all hormones that are formed on the backbone of cholesterol. Calcitriol has got a huge similarity with that. We now also know that it is vitamin D metabolism and action is a very sophisticated biochemical process that probably involves a vitamin D endocrine system. This system encompasses the active form of vitamin D, which is calcitriol, and calcitriol or vitamin D metabolism and action requires specific enzymes like many hormones, and the specific enzymes that catalyze this do metabolize the different components of the metabolic intermediaries of vitamin D. And vitamin D also have got an identifiable, clearly known receptor like any hormone does, unlike the vitamins. And it also has got a dedicated transport system by a protein specifically meant for it. Again, similar to hormones, not too many of the enzymes, the vitamins. And also there is a regulating hormone that regulates the synthesis and the catabolism of vitamin D, particularly PTH. So all these things combined would make vitamin D an endocrine kind of molecules and a simple vitamin. So people prefer this to call it a hormone than a simple vitamin. Vitamin D is now being recognized as a major global health, public health problem, as I've said, because of several literatures and publications on it. We now know that nearly 1 billion people, 1 in 7 or 1 in 8 individual in this world is vitamin D deficient. If you take a subclinical form of this vitamin D lack, hypovitaminosis D, if you take the subclinical form, nearly as much as 50% of the global population might have it, subclinical vitamin D. If we take any two individuals, one probably has got some sort of a deficiency or an insufficiency of vitamin D. But these figures are hugely prevalent in extremes of ages, in the elderly and in the very young, and it's also very prevalent in women of childbearing age. Even at the subclinical level, vitamin D is known to be associated with skeletal abnormalities, particularly osteoporosis, fall, and associated fractures, particularly in postmenopausal individuals, women, and elderly individuals, gentlemen. We said that traditionally we know that vitamin D has got a very important clinical effect in the musculoskeletal system. And this is done through the homeostasis of calcium and phosphorus, where bone metabolism is controlled. But recently, new functional role of vitamin D, as I've said, has linked it to other clinical conditions, more important, very deadly, and highly prevalent clinical conditions, the non-communicable diseases. And also vitamin D is known to be associated to some degree to the immune system. Then the consequences of vitamin D includes bone development abnormalities and chronic diseases. So if we talk of the chronic diseases, we basically are talking of something related to glucose metabolism, cardiovascular disease. When we talk about vitamin D, obesity is also an important clinical condition associated with vitamin D as a cause of vitamin D deficiency or insufficiency. Vitamin D is also very much associated with infectious diseases, with association. I'm talking about association, not cause effect yet, but there is a huge association with infectious diseases. The source of vitamin D, as you all very well know, is basically a dermal synthesis, a photosynthesis that is a resultant effect of the UVB light striking on the skin and converting the cholesterol backbone, which is a provitamin D, to a vitamin D25 hydroxy vitamin D, and then 125 dihydroxy vitamin D at the end. So the major source of vitamin D is skin synthesis. Then once it is formed under the skin, it is transported, bound to a vitamin D binding protein, then goes to the liver, where the first step of hydroxylation takes place, a 25 hydroxy position hydroxylation. Then this is subsequently transported into the kidney, where it is enzymatically hydroxylated at a 1 alpha position or at a 24 alpha position, making it active or inactive vitamin D ultimately. 125 dihydrocholecalciferol or 24-25 dihydrocholecalciferol. What is the optimal healthy sun exposure to result in this vitamin D synthesis? We do not know. What extent of vitamin D sun exposure, UVB light exposure is healthy is not a clear thing to recommend as a specific cutoff point of exposure, cutoff point of surface to be exposed. Only 20% of vitamin D is absorbed from the nutritional source in the GI tract. So 80% comes from sun exposure. Then the ultimate thing, as I said, is hydroxylation at different target sites. Does latitude have anything to do with vitamin D? True. Latitude has a significant thing to do, particularly people who live in the tropics. In the tropics, we know that between 23 degrees north and 23 degrees south is a region of this globe away from the equator, and this is the place called the tropical region. These tropical areas are known to have almost a year-round sun exposure. And when the latitude gets higher than the tropics, meaning in the north or southern hemisphere, the intensity of the light and the angle of the light that strikes the earth becomes so insufficient that vitamin D synthesis does not be optimal. So the further you go from the equator, the more distant you go from the equator in either directions, then you will have a very light strike, a very poor intensity of light and very insufficient angle of exposure to the skin of sunlight, UVB light for vitamin D synthesis. Vitamin D receptor is, as I said, is a distinct structure. And one important point to note in this vitamin D receptor is it is basically found in most parts of the body's tissue. This has got an implication clinically. We do not have vitamin D receptor only in the parathyroid gland or only in the skin or in the GI tract. We have it in a number of tissues in the body, in human physiological structures. So many tissues do harbor vitamin D receptors. This has got an importance in terms of the things that we're going to discuss. Conversion of vitamin D to its active form, 1,25 dihydrocholecalciferol, can take place in the skin, obviously, in the prostate gland, in the brain, in the pancreas, in the adipose tissue, skeletal muscles, heart, colon, macrophages, even neoplastic tissue. So this is very important. This is very important for the action or undesired effects of vitamin D insufficiency in humans. As the age advances, the receptors dwindle down, they decrease in concentration. So that's why elderly, one of the reasons why elderly individuals are predisposed to vitamin D deficiencies, the receptors do decline as age advances. This is a summary of what I said in terms of vitamin D metabolism. This is a pro-vitamin D, 7-dehydrocholesterol. This 7-dehydrocholesterol on exposure to sunlight would be converted to vitamin D3. Vitamin D3 is the human form. Vitamin D2 is what we obtain from elsewhere, from diets, from plant sources. Anything that comes from animal sources, vitamin D3. Anything that comes from plant sources, vitamin D2. Then that is transported by the binding protein to the liver, hydroxylated at 25 position, then transported to the kidneys. One hydroxylates it to 125 dihydrocholecalciferol, which is a potent active form. And the inactive metabolite can also form in the kidney, where 24 position is hydroxylated instead of a 1 position. But that is not physiologically active, that's not biologically active. The biologically active is calcitriol, or 125 dihydrocholecalciferol, which facilitates calcium absorption, bone resorption, and reduce calcium and phosphate excretion. By doing that, increases the serum concentration of calcium. What is the optimal vitamin D level? To determine the serum, the human body's optimal vitamin D level, the store form. All right. Do you hear me now?
Yes, please.
Do you hear me?
Yes, please.
Sorry. Okay. So the storage form of vitamin D in the body is in the form of 25-hydroxyvitamin D. So what you measure clinically is 25-hydroxyvitamin D. 125 is not very much long in its half-life in the circulation, so it does not show us the body's store of vitamin D. So 25-hydroxyvitamin D is what you measure in the laboratory measurements. The cutoff value for vitamin D deficiency or insufficiency is always a point of controversy again. Some consider a value greater than 30 nanograms per ml, which is in molar units, 75 nanomole, is sufficient, and anything less than 20 is deficient. Others use 20 as a cutoff for a normal value. Anything less than 20 is considered to be deficient or insufficient. Now, this table shows two different recommendations. This is the Institute of Medicine guideline, where anything less than greater than 20 is considered to be sufficient. But in the Endocrine Society guideline, anything above 30 is sufficient. Anything between 21 and 29 nanograms, this is in gram units. If you use a molar unit, multiply this by 2.5. And anything below 20 is considered to be deficient. And this is what is widely used. The Endocrine Society's guideline is what's widely used. But there are centers, there are individuals who prefer using this, but most of the studies and most of the data that we have, and probably the optimal vitamin D level that people consider is above 30. So the Endocrine Society's guideline is probably what is considered to be widely used. But again, you would find an article based on this cutoff points. What is the threshold level that is responsible for fracture occurrence? Again, this is very, very controversial. In one large study here in elderly individuals, values above the 50s, low 50s, is associated significantly with clinical manifestations. When individuals who have got a vitamin D level of 25-hydroxyvitamin D level of greater than 61, compared to those who have got less than 30, this is in molar units, divide this by 2.5 if you want to know it in nanograms, in gram units. So any individuals who have got values greater than 60 and values less than 30 are compared, and when the values go above 61, then there is a 37% reduction in the fracture of the hip. There is a 31% reduction of fracture at the non-vertebral sites. So values above the 50s are said to be quite safe in terms of fracture. What causes vitamin D deficiency? Vitamin D deficiency is caused by lack of sun exposure for different reasons. In some places, because of the season naturally devoid of UVB light or sunshine, and others for different reasons of be it associated with lifestyle or health issues or institutionalization, cultural issues, religious issues, a number of factors. Insufficient sun exposure is an important cause for vitamin D deficiency. Sunscreen and sunblocks are very important causes of vitamin D deficiency. Both of these, both sunscreen and sunblocks, completely block photosynthesis of vitamin D. They completely block it. Individuals who regularly apply this would have complete blockade of synthesis of vitamin D in vivo. Aging, as I've said, is one cause of vitamin D deficiency. One of the reasons being dwindling down of the receptors. Covering of the body, such as veil covering, veil dressing, skin pigmentation itself. The more pigmented the skin is, the higher the chance of vitamin D deficiency. Malabsorption of vitamin D can also occur as a result of other malabsorptive conditions. Obesity is a very important cause for vitamin D deficiency. Obesity is an important cause because the larger the visceral fat area, this is one important factor. One good study has come up in China recently. The larger the visceral fat area, the higher the vitamin D deficiency level is. This is because vitamin D is a fat-soluble vitamin. It distributes along the surface areas of the fat. the visceral fat, particularly being a large body surface area of fat. That causes vitamin D deficiency. Vitamin D can be catabolized or lost very fast. Medications are responsible for fast catabolism, breakdown of vitamin D. Anticonvulsants are important causes of vitamin D deficiency. Some antifungals, some ART medications are also important causes of vitamin D breakdown. Nephrotic syndrome results in loss of vitamin D binding protein, ultimately resulting in vitamin D deficiency. Breastfeeding is another cause of vitamin D deficiency, particularly exclusively breastfed children. Decreased hydroxylation, as I said, in the liver and the kidney can also result in deficiency of the active form of vitamin D. So what are the consequences of vitamin D deficiency? As we have said earlier on, it results in reduction in calcium and phosphate absorption, hypocalcemia and hypophosphatemia, as a result of which secondary hyperparathyroidism results, and then that results in bone demineralization. As a result of low calcium, high PTH, osteomalacia can occur in adults and rickets can occur in children. Rickets before fusion of the epiphysis, and osteomalacia once epiphysis has fused in adult patients. Then bone demineralization or poor mineralization of the bone is something that takes place. Beyond the skeletal structures, vitamin D deficiency, we said, is associated with a number of clinical conditions, particularly chronic non-communicable diseases and the immune system. Vitamin D is known to inhibit cellular proliferation and induces terminal cellular differentiation. Lack of vitamin D results in lack of this. Vitamin D also inhibits angiogenesis, which is an important process in tumorigenesis, in cancer cell growth. Then lack of vitamin D can also be associated with loss of this inhibition of angiogenesis. Vitamin D stimulates insulin production. Lack of it results in the opposite. And vitamin D is an important inhibitor of the renin production. Once you have got significant reduction in the vitamin D level, renin production significantly decreases. So angiotensin, aldosterone pathway, the RAS pathway, renin-angiotensin-aldosterone pathway is impaired, increased renin production, hypertension causation that comes from it. Vitamin D also stimulates production of antibacterial molecules, cytokines, and different mediators. So vitamin D has got an important role in individuals of. Then musculoskeletal and non-musculoskeletal effects of vitamin D. Musculoskeletal effects, if you break down this manifestation to its specific components, intrauterine skeletal mineralization is dependent on vitamin D. So maternal vitamin D deficiency has got an important consequence in the child. Rickets in child, osteomalacia in adults, and also decreased bone mineral density is an important consequence. Non-specific muscle pain, low muscle strength, and a fall resulting from that, resulting in osteoporotic fracture, are the major musculoskeletal effects of vitamin D. The studies suggest that if you supplement elderly individuals with low dose of vitamin D, 700, 800 international units of vitamin D per day, then these individuals would have significant reduction in the fall incidences, and as a result, there is a significant reduction in fracture at different parts, particularly hip fracture. Non-musculoskeletal effects, as I've said, has got wide-reaching consequences, particularly autoimmune diseases, atopic dermatitis, cardiovascular disease, chronic respiratory diseases, type 1 and type 2 diabetes, cancers, osteoarthritis, periodontal diseases, a number of other conditions are found to be associated with significant deficiency of vitamin D. Vitamin D deficiency in latitudes greater than 37 degrees are associated with an increased risk of chronic conditions. Chronic diseases are very abundant in areas of high latitude where vitamin D deficiency is rampant as well. What about the association of vitamin D with an infection? Vitamin D is associated with increased risk of respiratory infections, and an association of serum vitamin D of less than 40 nanomole with acute respiratory tract infection is established in a Finnish study in men. And in another school children trial in the US, vitamin D supplementation was found to be significantly associated with reduction in seasonal influenza A occurrence. Vitamin D appears capable of inhibiting pulmonary inflammatory response in studies. This is a NIHANS survey data. As you can see here, individuals who are vitamin D deficient, the gray bar, the light gray bar, or light blue, you may call it whatever color you may see on your screen. These ones have got individuals with very low vitamin D level, have got recent upper respiratory tract infections at a more higher prevalence than those who have got a vitamin D level of greater than 30. This has occurred in all the seasons of the year. So the higher the vitamin D level, the lower the incidence of vitamin D upper respiratory tract infection in individuals studied in this, reported in this enhanced survey. What about COVID-19, the current problem? Does it have anything to do with vitamin D? There are some associations reported from early in the pandemic, from April and May. And one of the first reports is from Holick and his team from the United States, where he has said vitamin D level in the US has, those who have got sufficient vitamin D in the US have as much as 54% reduction in getting COVID infection. But the cause and effect relationship is not established in this report. The studies are adding to the accumulating data, showing that an association between higher serum level of vitamin D and better outcome in patients with infection, COVID infection. This is one just recent September publication from Iran, where they have reviewed patients with COVID, severe COVID disease that required inpatient care. So among these individuals, 235 patients were admitted, and their mean age is about 58 years, and they are individuals who have got very significantly low levels of vitamin D. 67% had low vitamin D level, defined as a vitamin D level of less than 30 nanogram or less than 75 millimole. Patients who have sufficient levels of vitamin D of greater than 30 compared to those who are insufficient, there is a 63% versus 77% severe outcome. Those who are insufficient and deficient, and those who are not. 63, those who have got sufficient vitamin D, 77 who have got vitamin D deficiency, which has got a significant p-value. Death as well is of similar magnitude, 20% versus 9.7% in COVID and deficient or insufficient individuals versus the sufficient ones. So this difference has maintained after adjusting for different factors that could have affected the outcome: age, sex, body mass index, smoking, history of chronic medical conditions. After adjusting for this, the difference persisted. In another study in northern Spain, vitamin D deficiency was abundantly found in patients with COVID infection. And the mean value of vitamin D in COVID infected individuals is 13% compared to 20.9% in population-based controls. Vitamin D deficiency was found in 82% of COVID infected individuals versus 47% in the general population, control population. And in this study, an important thing to note is no cause-effect relationship is established. It's only establishment of the level of vitamin D and COVID occurrence. Otherwise, whether COVID is caused or worsened by the vitamin D status, no relationship is established in this study. However, it is very important to recognize that the association reported in observational studies that we've seen earlier on is not necessarily a cause-effect relationship. So we need to wait for controlled trials, randomized controlled trials. But in the meantime, since vitamin D is a very safe drug and supplementing vitamin D has no harm to do, many people do agree that supplementing individuals who have got COVID with a low dose supplemental dose of vitamin D would be something of a reasonable approach. The postulated mechanisms in COVID infection is patients with vitamin D insufficiency have significantly higher levels of inflammatory markers from these studies. These inflammatory markers probably would predispose individuals to the cytokine storm, or at least worsens the cytokine storm that occurs. Vitamin D also modulates the renin-angiotensin pathway, where ACE2 receptor is implicated in COVID pathogenesis. So this modulation probably has an implication in vitamin D's effect, desirable effect of vitamin D in COVID disease. In autoimmune disease too, vitamin D is known to be associated with an important clinical conditions such as type 1 diabetes. Again, Finland is the place that we keep quoting in type 1 diabetes because of its high prevalence of type 1 diabetes. Then in Finland, type 1 diabetes risk reduced by 78% with vitamin D supplementation at a dose of 2,000 international units per day. Children who are at risk of rickets is 3 times higher having type 1 diabetes. Again, this evidence came from this argument. In Finland, daily vitamin D supplementation recommendation was gradually reduced by authorities from between 4,000 and 5,000 a day. This is the earlier recommendation. In 1964, they reduced it to 400 international unit per day recommendation since 1992. After the authorities have reduced these guidelines, the prevalence, the incidence of type 1 diabetes has serially increased in different age groups. And now in 2006, authorities again required that all dietary milks to be fortified by vitamin D2. And after that, they claim that the incidence of type 1 diabetes is gradually decreasing since then. But again, cause-effect relationship is not clearly established with randomized control studies, but association is very important. This is a summary of different type 1 diabetes studies. Again, a number of studies, case control studies, have associated vitamin D supplementation in early age and during pregnancy with reduction of childhood diabetes, type 1 diabetes. Again, these are not well-designed big studies to be a huge evidence. But cancer is also associated with vitamin D. As we have said, because of its angiogenesis effect, vitamin D can have a significant impact in cellular growth and differentiation in tumor formation. And we said that vitamin D receptor is there in a number of body tissues, including the colon, the white blood cells, the ovaries, the breast and prostate. So vitamin D and calcium has been associated with an increased risk of NHL, colon CA, ovarian CA, breast CA, prostatic CA, and other cancers. Higher levels of serum vitamin D leads to a lower incidence of cancer. Sunnier latitudes have got low mortality. Probably people think that this is because of the contribution of vitamin D. Black individuals have got high degree of affection by different cancers, colon cancer, breast and prostate cancer. There could be a number of other reasons for this explanation. Vitamin D also stands to be one of the reasons in this causation. This is supplementation of vitamin D at a dose of 1,000 international unit over a 4 years period, and breast, colon, lung, and leukemia, multiple myeloma incidence has been followed. Individuals who have got supplementation with calcium and vitamin D, and calcium alone and placebo. As you can see, the difference between the supplemented groups and those with placebo follow-up is significant in terms of cancer-free survival. Again, this is vitamin D level versus breast cancer and colon cancer. These ones are with insufficient vitamin D or deficient vitamin D. These ones are for individuals with sufficient vitamin D. And the rate of breast and colon cancer, as you can see, is significant compared at a global perspective. These are studies, different studies pulled together. Vitamin D in cardiovascular disease is also another important thing to consider. Vitamin D is an inflammatory, has got an inflammatory effect, anti-inflammatory effect in the blood vessels particularly, and low vitamin D level is associated with twice increase in cardiovascular event incidences. The highest rate of cardiovascular disease was observed in those with hypertension and vitamin D deficiency combined. Vitamin D has got an effect in the macrophage where it decreases the uptake of oxidized LDL particle. It also decreases from cell formation and all the steps of atherogenesis in the blood vessel. So vitamin D probably, its receptor in the macrophage has got an implication in this. Type 2 diabetes, insulin resistance versus vitamin D. Again, the NANSRI in the United States has got a review of individuals who have got vitamin D levels, insulin resistance, and type 2 diabetes. Then there is a dose-dependent inverse association that has been noted between the levels of vitamin D, insulin resistance, and type 2 diabetes. The lower the vitamin D is, the higher insulin resistance in type 2 diabetes in that NIHANS data. This is hypertension and vitamin D. As we have said, the RAS system probably is a central system that's affected by deficiency of vitamin D. So the more deficient the vitamin D is, the more activated the RAS system, the more hypertensive molecules produced in the renin-angiotensin-aldosterone system, then hypertension comes up. Other effects are effects on pregnancy, preeclampsia, preterm births, and early infant outcomes, including low birth weight, stunting in the first year of life. So individuals who have got vitamin D deficient probably has got undesired, untoward outcome in pregnancy. But again, this is only inconsistent. In some studies, association has been proved. In others, an opposite, no association has been demonstrated. So this is an inconsistent finding yet. So this is a cardiovascular summary studies. I'm sorry, do you hear me?
Yes, please. Yes, Dr. Tedla.
The horn of the car from outside my office is disturbing. Let me close my window. A second, wait for me.
All right.
All right, I'm back, thank you. So the conclusion from the CV data indicates that cross-sectional and longitudinal studies have shown association between vitamin D level and chronic non-communicable disease, particularly MI, mellitus, hypertension, heart failure. But this is in cross-sectional and longitudinal studies. But interventional studies did not show as a strong evidence. So this means that we need to have a large randomized controlled trial for conclusion. But there is an association that's established in this. The other thing is vitamin D also is associated with multiple sclerosis, causation as well as progression of multiple sclerosis. A large number of people have been followed with vitamin D levels, supplementing vitamin D. There is an association between multiple sclerosis prevalence of multiple sclerosis, progression of multiple sclerosis, and improvement when vitamin D is at an optimal level. So this is an association of multiple sclerosis and vitamin D. These are the mechanisms I have already touched upon, where possible mechanisms of vitamin D on non-musculoskeletal effects. This is in the macrophage. Macrophage has got a vitamin D receptor. Then ultimately, the immune modulation goes on in this after stimulation of the vitamin D receptor and then activation of the immune system, activated T lymphocytes, activated other lymphocytes, cytokine production, and the B lymphocytes producing immunoglobulins. So this is a pathway through which it might affect the immune system. And this is a skeletal affection where parathyroid hormone regulates it. This is a blood pressure where the renin-angiotensin-aldosterone system is affected and hypertension comes. This is the pancreas where insulin secretion and insulin resistance is induced and insulin secretion is diminished. So this is an important thing to consider. This is in the cancerogenesis or angiogenesis in tumor cells. So it might be through these mechanisms that vitamin D has got an multiple structures. So the next part is hypovitaminosis D in developing countries. Hypovitaminosis, does it occur in developing countries? First, let's see this graph, this map. Most developing countries do live between these latitudes. Most of them, the colored or the shaded and the colored ones are developing countries. Majority of the developing countries do exist in close to the equator, in the tropical regions. As you can see, this is 23° north and 23° south. That is a 40° mark, and that's a 40-degree mark. A significant number of these developing countries are either in the tropics or very close to the tropics. This includes Ethiopia. Hypovitaminosis D is a prevalent disorder in developing countries. It is a widespread disorder in all age groups in these areas. In addition to infectious diseases and malnutrition, it is an important childhood problem causing rickets. And the prevalence of hypovitaminosis D varies widely by region and within a region. The high prevalence of hypovitaminosis D exists in a number of developing countries, despite the fact that the large number of these countries do exist in the zone where there is sufficient year-round sun exposure. The prevalence ranges between 30 and 90% from different developing countries and low and middle-income countries that I showed you. Some reported as much as 90% in the populations they have studied, others reported as low as 30% with low levels of vitamin D, between 30 and 90%. This very wide variation between the figures is because of the methodology that vitamin D is determined with, and the cutoff values are very variable, as I have said earlier on. But whatever the case might be, the numbers are very huge. Hypovitaminosis D occurs in these areas with all the clinical manifestations that we have discussed for developing countries. There is not much difference in the clinical manifestation between low and middle income countries or developing countries and the Western or advanced developed countries. So manifestations are both musculoskeletal and non-musculoskeletal. Then studies published in the last decades. 1/3 of sub-Saharan African population and the Middle East population have got vitamin D level of less than 25 nanomole. This is 10 nanogram per ml. As you can see, very, very huge number. 1/3, 30% of these sun-bathed areas of the world, sub-Saharan Africa, and very arid and dry and very hot Middle Eastern countries have got that degree of vitamin D deficiency. That's the severe vitamin D, nearly severe vitamin D deficiency level that is noted. In the Arab Gulf and North African countries, including Egypt, Lebanon, Tunisia, and a number of others, show high prevalence of hypovitaminosis D. The cause for this probably is partly related to cultural practices. Others could be as a result of skin hyperpigmentation or dark skin, avoidance of outdoor sun exposure because of the harsh weather. So this could be among the factors. High prevalence of the disease exists in other non-African developing countries of middle and low and middle income countries. In China and Mongolia, for instance, a vitamin D deficiency of up to 50% have been reported in studies. And these are individuals who have got very severe vitamin D deficiency of that degree. 0.5 is, this is about 5 nanograms per ml. Very severe vitamin D deficiency. In Brazil, the same has been reported in a high number. In this Brazilian data, resident physicians are found to be very significantly vitamin D deficient. So you guys have to watch out. You might be very much deficient because you come into work early in the morning, you go out from work quite late in the evening. You have very little chance of exposing yourself to sunlight. So among others, resident physicians have been studied in this Brazilian data. Ethiopia, what about Ethiopia? Do we have any evidence that we are vitamin D deficient? Again, the data that we have are small healthcare facility-based studies, but we have significantly important data to quote. One study that has been done in this Tukurambasa Hospital at the Radiotherapy Center on breast cancer individuals, 41.1% of these individuals who are on chemo-naive individuals with breast CA are those who have got vitamin D levels of less than 41. And on the tamoxifen treated group, the vitamin D level of less than 25 was identified in 11%. 25 is 10 nanograms. This is a cutoff for severe vitamin D deficiency. So in these individuals, significant proportions have got very severe vitamin D deficiency. And Dr. Guta has reported from the Hulshet Clinic and in the Journal of this is just a recent publication of Ethiopian Journal of Health Sciences, where all of his patients that he has revised, this is a clinical review, a retrospective medical record review. Vitamin D of less than 30 nanogram per ml is found in 62.9%, and levels of less than 12 nanograms have right in 62.9%. All of the patients have got a vitamin D level less than 30. Less than 12 nanogram is in 62%. Another study by Tasamma and his friends on smear positive tuberculosis in the North Gondar, North and Southern Gondar zones. Deficiency is identified in 61% of smear positive tuberculosis patients and 38% of their household non-tuberculous contacts. Another report is from Tolosa, from Adama, where individuals 42% of school children between the age of 11 and 18 randomly selected have got a vitamin D level of less than 50 nanomoles. This is about 20 nanogram per ml. This is from Adama. Another report. Yes, yes.
We are running out of time. Can you summarize? It is really an excellent, and just I'm following it very well, but the time is going. So
right, okay. We started quite late. So I just took 35 minutes so far on my time. Okay, I can summarize. So then another study from southern Ethiopia is from Tafarra, where only 15% had sufficient vitamin D levels. This is non-pregnant woman. And another study from the Rambas Hospital, unpublished MSc thesis, 88% had deficiency and 12% have insufficiency. All 100% with non-specific musculoskeletal presentation have got vitamin D abnormalities in this study too. Available data are very much limited, as I've said. They are descriptive and population-based. Methodologies are variable, so probably we need to have a stronger data. Risk factors are similar to the risk factors that we have elsewhere. Extremes of ages, multiparity, winter season, dark skin pigmentation, lack of sun exposure, and so on are major causes, just like anywhere else. Air pollution in one study has been found to be a possible cause by blocking the UVB light penetrating to the ground, but that again is a very single study. Again, this is a summary of the developing countries' data. And which foods do contain vitamin D? Vitamin D is not available in many of the foods that we consume. It's basically seafoods that have got vitamin D. And even the amount that the rich seafoods contain is much less than the daily requirements that is recommended. But generally, it is the seafoods and very little in eggs, beef liver. For instance, egg have got one big size egg has got a 44 international with vitamin D. If your daily requirement is 800, you need to eat 20 eggs a day. That does not give any sense. So food source is not a very reliable source. This is a daily supplement recommendation, daily recommended vitamin D. It ranges between 400 and 800 international units a day. And unsupervised vitamin D supplementation should not exceed 4,000 international units a day. Anything that's taken beyond this has to be supervised. Vitamin D level has to be measured. This is dependent upon the age of the individual, but maximum that can be tolerated unsupervised supplement is 4,000 international units a day. Vitamin D preparations are different in their types. Cholecalciferol, vitamin D3, which is a natural molecule, which is more potent than vitamin D2, and ergocalciferol is a plant source of vitamin D, less potent, and it's plant derived. And the active forms and the hydroxylated forms are reserved for individuals who have got kidney and liver disease. Combinations tablets are not very much recommended because they are not very palatable. They are recommended for severe cases and individuals who have got osteoporosis. Otherwise, vitamin D alone is sufficient. And high dose vitamin D is required in deficiency states. The dose depends upon the level of the vitamin D. Enteral route is preferred. Parenteral is only when enteral is not available. Closely monitored serum level is required when high doses are administered. And vitamin D key points are it's very common in tropics, And clinical manifestations are of musculoskeletal and non-musculoskeletal probably, but the musculoskeletal is what's clearly known and might be associated with a number of infections in the cardiovascular and cancer occurrences. Clinical trial data are required for conclusion purposes. And sun exposure, as I've said, there is no optimal sun exposure time that is known, but 10 to 15 minutes a day, reasonable exposure of the body. The arm, the upper arm, the head, and the neck is probably sufficient if exposed for this duration, but dark skin individuals should be exposed for a longer time. And recommendations are there when the prevalence of vitamin D level is less than 30, now normally more than 20% of the population, or the risk of the rickets prevalence is greater than 1%. Foods have to be fortified in the country. This is a national policy that has to be based on this if fortification has to be done. Thank you. I think I'm done.
Yeah, thank you, Dr. Tedla, as usual, an excellent presentation. And I feel that you clicked on everybody to associate all his specialty with the vitamin D deficiency and association. And this is an excellent presentation. And maybe I will invite, yes.
Hello, Dr. Tufir. I just have some comment.
Yes, Professor.
Okay, good morning, everyone. And I would like to thank Dr. Tedla. Can you hear me, Dr. Tufir?
Yes, please go ahead, Professor.
Okay, great. So I just want to give a brief comment because of the time. I just want to say thank you, Dr. Tedla, for excellent presentation, as well as for updating us on the subject. And currently, you know, vitamin D deficiency is associated with metabolic abnormalities and systemic illnesses. All the lists were stated, like diabetes, hypertension, cardiovascular disease, seizure disorder, neuropathy, fractures, cancer. Everything is associated with this vitamin deficiencies. Means that almost all disciplines should look for its association and order the test probably and manage the patient appropriately. I share the point raised by Dr. Tedla with Ethiopia is a country of 30 months of sunshine. I had this hypothesis years and years ago, and I did a study in collaboration with Norwegian group and found out that the study was conducted in young adult and pregnant women, and we found out that our population, the study population in Ethiopia, were having this significantly high level of vitamin D deficiency compared to Norwegians. This article was published in European Journal of Endocrinology, and this is one of highly cited articles. I didn't see this article from the list of Dr. Tedla's publication. Probably he chose the latest one. So please, anybody who's interested can go and read European Journal of Endocrinology. It's highly cited article. The other point that I have is, I think we have recognized this problem as a problem of our patients, and faculty members develop thematic research, and this research, thematic research, is well known by the department and the faculty. So far, we have done part of the thematic research and 2 papers. One paper is almost accepted for publication. The other one is online for publication. The other studies of the thematic research, also there is a clinical trial component. Everything is delayed because of COVID. I hope by now we'd have our own data, but all activities were delayed because of the COVID and the requirement of large research grants. So this is just to keep you alert. And interestingly, you'll see the publication which was done on the knowledge attitude practice of health practitioners. We did qualitative and quantitative study. I hope I'll let you know when these things are published. So because of the time factor, I will stop here. Thank you very much for giving me a chance to comment on the presentation. Thank you.
Thank you, Prof. And any other comment from staff?
I have a question.
Yes, please.
Dr. Tedla. Dr. Tedla, yes. Thank you very much. It was really excellent and insightful presentation. My question is that do we know the normal value for people from the tropical area? Can it be our normal value, the lower value, like the white cell count is very low in our community? So is that the same, or what do you think? You know, because we don't see much of the complications like the fractures and the leg, but despite that, we are prone to infections due to our other different reasons. So what is your comment on that? Thank you. And also probably the effect of vitamin D on sexual dysfunction and other issues. Thank you.
Thank you, Dr. Tedros. But with regards to what is the cutoff point in different populations, is very difficult to answer. Because as I have said, leave alone in a specific country, in a specific population, even the global cutoff point is not yet a point of agreement. There is an argument on it. But generally, in African countries, many studies have been done, although they are very small, clinical studies, observational studies, association studies. And these studies do recognize that individuals who have got symptoms of one type or another are those individuals who have got a vitamin D level of less than 30, in some less than 20. So probably we are not much different. If you have noted what I projected from the Ethiopian data, one of the data was Dr. Guta's data. And in that data, individuals who have got musculoskeletal manifestations of vitamin D deficiency or insufficiency, when they are supplemented, the symptoms have gone. So that level has got some degree of clinical implication. Although it might not have gone to the extent of fracture causation, it has got a clinical implementation. That's what it indicates. In our routine daily practice too, when we encounter individuals with non-specific fatigue, non-specific pain, all investigations are done, nothing revealing, then vitamin D is done. It's found to be low. You replace it, patient's okay. Probably the values that are used elsewhere is not much different from the values of our patients here. But to be scientific, you need to have a study done. You need to have established population cutoff values, and that has to be answered by subsequent answers. ED versus vitamin D deficiency. Well, I have not encountered specific data or literature on that, but vitamin D deficiency is associated with obesity and cardiovascular and metabolic diseases. This can result in ED. So is it the ED that comes from the vitamin D deficiency, or the ED that comes from other obesity and metabolic cardiovascular disease associated conditions? That is a little bit difficult to do a control study on. But generally, in individuals who do not have these comorbidities, one can do a study and see if ED is associated with vitamin D and improves with vitamin D correction. But I did not encounter any data or literature. Saying so, I would like to thank every individual that have given me in the chat box encouraging compliments. Thank you, everybody.
Dr. Tedla, can I ask one practical question?
Please.
We see patients with vitamin D deficiency, and people are giving a different duration of treatment. Like some give for 8 tablets of the 50,000, others 12, others for 1 month. How do we determine the duration of treatment if we want to treat with a higher dose? And for whom do you recommend the supplement? And for whom do you recommend the higher doses, and for how long? Thank you so much.
Yeah, that's an important question and clinically encountered. High dose vitamin D treatment is not recommended without supervision. That's the first thing. And individuals, the recommendations are also different, by the way. Some individuals do recommend in vitamin D deficient individuals, values less than 20, you treat them for 8 weeks and then test the vitamin D. But in very severe deficiencies, deficiency less than 10 nanograms per ml, you treat for 3 months and then go and get a checkup. So it all depends upon the degree of the baseline vitamin D deficiency or insufficiency. Individuals who are vitamin D insufficient may not require the full dose of high dose vitamin D weekly or bi-weekly treatment. Relatively higher dose of supplemental dose can correct insufficient values between 20 and 30 nanograms. So you can give between 2,000 and 4,000 international units a day of vitamin D3 per os for individuals between 20 and 30, and monitor the level in about 8 weeks' time. But individuals with severe deficiency, you might even require to give twice a week of the 50,000 high-dose vitamin D. By the way, you have a vitamin D preparation of 20,000, that's the D2 oftentimes, 50,000 and 60,000 oral preparations. So the 50 and 60,000 are not much different in terms of the effect. In severe deficiencies, at least in the first 1 or 2 weeks, you can give twice a week if the deficiency is severe enough. Twice a week, and then taper it down to once a week, and then determine in 3 months' time. But individuals who have got reasonable vitamin D levels but deficient between 10 and 20, a weekly vitamin D for between 2 and 3 months, and then determine the vitamin D value. And the ideal is achieving a vitamin D value of about 50 or 60 nanograms. But anything above 30 is sufficient. But the chance that it recurs, it drops back, is very likely if a patient does not exercise, adequate sun exposure, or supplement treatment. So you have to advise your patient for adequate sun exposure and supplement treatment, vitamin D supplement at a low dose if that is possible, and dietary, if possible, diets rich in vitamin D, which are not abundantly found and widely found. So recurrence can be avoided that way. Otherwise, a continuous regular sun exposure is the best remedy out once you have corrected the deficiency. Otherwise, a marginal correction of 30 or 35 can easily come down to deficiency if patients are not exercising these preventive measures. But generally, between 2 months and 3 months, monitoring is required in high-dose vitamin D.
Thank you so much. If we don't have further questions, and if there is no message from the department for any other activities, most likely we have to end up our an excellent lecture at this point of time.
Thank you, Dr. Tedla, and thank you, Dr. DeFerra. I think let's wind it up because of the time constraint. Otherwise, we'd have continued. There is also some question, but there is a better communication.